nephrolithiasis. It simply means kidney stones. So stones can be in your kidney, salivary gland or gallbladder. The important point here is that if the stone is in kidney or salivary gland, you will be able to see that stone in the X-ray, because in salivary gland and kidney stones 80% and 90% are radio opaque stones. So you are very well able to see these stones on the X-ray, while the gallbladder stones 90% of them are radiolucent, so you cannot see them on X-ray. Anything which is radio opaque you will be able to see on the X-ray. Done. So moving on, we have four main type of kidney stones, which is calcium oxalate stones, phosphate stone, uric acid stones and cysteine stones. Now we'll study how these stones are formed in your body. First of all, calcium oxalate stone. See, it's very simple. Either calcium is increased in urine or calcium is increased in blood, which is called hypercalcemia or hypercalciuria. Then you will have calcium oxalate stones. Or if oxalate is increased in urine, which is oxaluria, you will have the stones. So simple. Either in urine calcium or oxalate is increasing, or in the blood calcium is increasing, then you will have this type of stones. Now what about phosphate stone? Say one day you get up in the morning and you get some infection of proteus bacteria. Now this bacteria will go inside your body, they'll release an enzyme called urease enzyme, and this notorious enzyme will convert urea to ammonia. This ammonia is making your urine alkaline. So what happened? A bacteria came inside your body, it released an enzyme which made ammonia, and this ammonia made your urine alkaline. Due to this alkaline urine, there will be precipitation of these three things, which is magnesium, calcium and NH4PO4. These three things are making phosphate stones. So it is called a triple stone. Now why everything happened? Your urine was normal at first, but because your urine became alkaline, there was precipitation of these three things. The exact opposite happens in uric acid stones. Now how uric acid stones are formed? Let's say you have a disease, gout or Leishman syndrome or tumor lysis syndrome. Any of these disease you are having. So what will happen to your body? There will be cell lysis inside your body. If the cell are breaking, then there will be breakage of DNA inside the cell. So this DNA will come outside. DNA is made up of uric acid. So uric acid will be released outside, and this uric acid obviously will make your urine acidic, and in this acidic urine there is precipitation of uric acid crystals. So what happened here is your urine became acidic. In the phosphate stones your urine became alkaline. So this was the etiology. Now what about cysteine stones? It's as simple as calcium oxalate stones. Here also it's just cysteine urea. And mind it, the cysteine stones are the hardest stones. Okay, the phosphate stones are most radio opaque stones, while calcium oxalate stones are the most common stone overall. So everyone has got some little thing of their own. Done. Now one more thing about phosphate stone is that, you see, this is the representation of kidney, and in this kidney there will be initially small deposition of phosphate stone, which over time period will make this type of stones. So it's a silent presentation, and it will take time for the phosphate stones to block your entire pelvic calcial system. So the phosphate stone present with silent presentation, and they have the worst prognosis. So these are dangerous stones. Now if you see here this part, you can see that the shape, it looks like a Stanghorn caliculi. This one. So the phosphate stones are called Stanghorn caliculi or Struwite stones. Okay, done. So now we are looking at crystalline images of these stones. The calcium oxalate stone appear dumbbell shaped if it's calcium oxalate monohydrate, or envelope shape if it's calcium oxalate stone. The phosphate stone, it's very easy, it's a coffin lid, like it's the stone is dangerous, it is having worse prognosis, so the lid is ready for your deathbed. It will look coffin lid in crystalline image. The uric acid stone look multifaceted. Here you can see there are many faces, one two three, so these are multifaceted or rosette stones. The cystine stones look like hexagonal benzene ring, and we all know that only uric acid stones are radiolucent while others are radio opaque stones. So if the X-ray doesn't show any stones, it can be uric acid because radiolucent stones are not seen on X-ray. Okay. So now comes the interesting part, which is clinical feature. So this entire slide you are seeing here, this full slide is just for pain, means I'm only going to explain you how the pain occurs due to these stones. So starting initially there is sudden severe onset of pain. And where is the pain? You see at the back there is an angle called renal angle, which is represented by 11th rib and paraspinal line, which is made by 11th rib again and paraspinal line. At this angle you will have fixed pain. If there is any stone inside your kidney, you will have pain. Now based on the location of the stones, there will be pain at different parts of your body. Simple thing, initially there is sudden severe onset of pain, and based on that location there is pain on different parts of your body. Like if the stone is lodged here in the upper one third of ureter, or pelvic in the pelvic ureteric junction, if the stone is here, then first of all, why there is the pain if there is a stone? Because the stone in the ureter, the ureter compresses to remove this stone. In that process you will experience pain. Or either if the stone is lodged here, then the entire fluid gets accommodated in this part, and this part gets stretched. So due to that there will be pain. So there are a lot of reasons of pain, but important thing is where will we experience pain? Like if there is obstruction in the upper one third of ureter, first you will experience pain at loin. What's loin? Loin is the side of your flank area. At that area you will experience pain, and it will radiate to the testis when, if the stone is in upper one third ureter. If the stone is in middle part of the ureter, then initially there is pain in the loin, which will be radiated to this iliac fossa, hypogastrium and the groin area. Once again, iliac fossa, hypogastrium and the groin area. Pain is radiated from loin to these parts when there is obstruction in the middle part of the ureter. If the obstruction is in the lower ureter, then pain from loin is radiated to the inner aspect of thigh and perineum as represented here. Now why this all is happening? Why the pain from your loin is going in all these stupid places? Because of these nerves. The nerve responsible for the upper one third ureter is subcostal nerve, then iliohypogastric nerve, then ilioinguinal nerve. You will learn this nerve in this sequence only. What's the sequence? Subcostal nerve, iliohypogastric nerve, and ilioinguinal nerve. Done. So this entire slide was all about the pain. There are other clinical features too, like in this diagram we'll study other clinical features. Like let's start from the very basic. If there is an obstruction here, then entire urine is collected in this part, so this part gets dilated. This dilatation is called hydronephrosis. Simple. If the stone is here, you'll experience pain, that we studied earlier. Now what happens is that, let's look at this diagram. Here you can see that initially when there is a stone, there is dilatation here. What will happen after some time? As the fluid increase here, it will put pressure on the stone and the stone can get dislodged. So when the stone goes away, entire fluid goes away, and this dilatation also reduces. So initially you had palpable kidney with severe pain. When there was a stone, you can palpate your kidney and there was a severe pain. When the stone goes away, there is large urine passage. All this fluid goes out as urine and there is decrease in mass and pain. So initially there was pain, then the pain is gone. This phenomena is called intermittent hydronephrosis. Why? Because the swelling or hydronephrosis is intermittent, is on and off. Here it's on, here it's off. After some time, what will happen? From this, there will be stone formation and so there will be again stone formation and then again this swelling will develop and then again hydronephrosis on, and all this is called Dale's crisis. So these were the clinical features. There are another clinical features too. Say, let's say this is the ureter and this is the calcium stone. We all know that the calcium stone is like this. It has sharp endings, so it can erode the wall and there can be bleeding. So other clinical features are hematuria and increased frequency of micturition. Why? Because if there is obstruction here, then the entire fluid cannot come out in one go. So there will be small frequent micturition. So the frequency of micturition increases here. Done. So now what are the investigation? Firstly, we'll do X-ray, USG and CT urography, which will be the investigation of choice, which will tell you about the location and where the stone is. Now important thing to understand here is the functional status assessment. Now what's this? So let's go in the very basic. First is DMSA, second is DIPA, and third is MEC3. Leave this for a while. DMSA is just a photo of your kidney, while DIPA is a video of your kidney. Means, let's say you click a photograph of your kidney. What does it show? It shows kidney structure, surface anatomy, and morphology. If you put a video or if you shoot a video of your kidney, then it will show the blood coming to the kidney, blood going away from the kidney, and the urine status. So how the kidney is functioning, that we know in DIPA, while the structure of kidney we know in DMSA. So DIPA assesses the renal function, while renal perfusion and renal function. Done. So if the renal function is less than 10%, then we do nephrectomy. We remove the kidney, provided the contralateral kidney has to be normal. You can't just kill your patient if the other kidney is also not working and you are removing this non-functional kidney also. But if the renal function is more than 20%, then you do all your attempts to save the kidney or salvage the kidney. Simple. And the gold standard test for renal perfusion is MAG3. Done. These were the functional status assessment tests. Simple. What one thing you have to remember is DMSA is a photo and DIPA is a video. That's all you have to remember here. Now what about management of these stones? Now let's say the management is purely dependent upon how your stone size is. If your stone is less than 5 mm, you don't have to worry. You just give him fluids, reduce his pain, and you'll be fine. Only conservative management is required. If your stone is between 6 to 20, it's not too big, it's not too small, but it's in between 6 to 20, then what you do? Then you subject the patient here and you put the extracorporeal shock wave lithotripsy. Means you just subject your patient to these shock waves and these shock waves will break the stone. So it is not a surgical procedure, okay? You are not cutting the patient or anything, you are just giving these shock waves from outside. So this procedure is called ESWL, extracorporeal shock wave lithotripsy, and it's done when the stone is between 6 to 20 mm. Now, if the stone is greater than 20 mm or there is contraindication for ESWL, means let's say your stone is 14 mm, then ideally you should do ESWL, but the patient has contraindication of ESWL. What are the contraindication of ESWL? We'll study in the next slide. But then we have to do these surgical procedures in the 14 mm stone also. Now what are these procedures? The first one is percutaneous nephrolithotomy. What you do, you cut the skin, you put something inside and you remove the stone. Simple. It's a surgical process which is percutaneous nephrolithostomy. The second procedure is you don't do any surgery, you just go via urethra, bladder up to the kidney and remove the stone. This procedure is called retrograde intrarenal surgery. This is kind of surgery you are not putting big marks or cutting anything of your patient. You are just going via urethra to the kidney and removing the stones. So obviously the simpler process is this. So if your patient is not suitable for ESWL, then first we'll do retrograde intrarenal surgery. If this also fails, then at last we are cutting the skin and percutaneous nephrolithostomy is done. So now we'll study these three procedures individually. Okay. So this procedure is ESWL. Now what's happening here is outside from outside the body we are throwing shock waves, and these shock waves will break the stone. Sometimes what happens is that the stone breaks and the pieces get dislodged here in the ureter. मीन्स ये जो स्टोन के पीसेस है वो यहीं पे फंस जाते हैं और बाहर नहीं जाते हैं, तो उसे हम बोलते हैं रोड ऑफ स्टोन्स और स्ट्रेन स्ट्रोस मैकेनिज्म. स्ट्रेन स्ट्रोस मैकेनिज्म मीन्स देर इज ऑब्स्ट्रक्शन, पहले था बाद में भी ऑब्स्ट्रक्शन है, सो इट्स अ कॉम्प्लिकेशन ऑफ ESWL. सेकेंड इज दिस शॉक वेव्स, ये जो शॉक वेव्स हमने डाली है वो हमारे टिश्यू को भी डैमेज कर सकती है. ड्यू टू दैट वी एक्सपीरियंस पेन एंड हेमेचूरिया. सो पेन, हेमेचूरिया, रोड ऑफ स्टोन्स एंड urinary tract infection are the complication of ESWL. Now there are certain conditions in which you cannot perform ESWL. If even if the stone is between 6 to 20 mm, you cannot do ESWL if your patient is pregnant, because the child will be affected because of this shock waves, or obesity. What happens in obesity is that there is a big layer of fat in obese person, so these shock waves won't be that effective because they won't be able to penetrate this fat layer and destroy the stone beneath. So you don't do ESWL in a obese patient. Now, if the stone is greater than 15 mm, you generally don't do ESWL. The criteria says 20, but if it's more than 15 ml, then you go with surgical procedures. Now, if the stone is in lower calyx, even if you break this stone by ESWL, it cannot go up outside to the bladder and the urine. Why? Because it's against the gravity. So you don't do ESWL in lower calyx stone or obstructed stone. If there is obstruction in the passage, obviously the stone will be broken by ESWL but cannot be removed from your tract. So done. If you have cardiac pacemaker, then also you don't do ESWL because the waves can interfere with the cardiac pacemaker and you don't want your patient to get heart disease for just stupid stones, right? So these were the contraindication of ESWL. Now the other two surgeries are retrograde intrarenal surgery and percutaneous nephrolithotomy. First, if you can't do ESWL, then you do retrograde intrarenal surgery. So you're going up the urethra, bladder and the kidney. Now in this part you either have laser which break the stone, or you have a dormia basket which collects the stone and removes it. Laser is of two type, Nd:YAG and holmium laser. If there is a laser here, then this procedure is called laser lithotripsy. Okay. Now, what are the indication of this surgery? Indication is firstly if the stone is greater than 2 centimeter or 20 stone, then you do this surgery. If the stone is in lower pole, obese patient, see these were the contraindication for ESWL. So these are indications for this surgery. Now, if there are bleeding disorders, hip spine abnormality, you do this surgery. Now, if this fails, then you do percutaneous nephrolithotomy. This one is the last surgery. Now again, what are the indications? If the stone size is more than 20 or 2 centimeter, it's a lower pulse stone, or your RIRS has failed, then you do percutaneous surgery. And in the Stenghorn calculi, you do percutaneous nephrolithotomy. Now, what are the complications? Complications are